Hi listeners, are you ready to elevate your skills in investigating psychological health and safety hazards? Our brand new 10-week Psychological Health and Safety Investigations program is designed for safety professionals and individuals looking to build confidence and capability in handling complex workplace incidents. Over 10 weeks, you'll dive into practical content, exploring how psychosocial hazards contribute to incidents like physical injuries, unsafe practices, workplace bullying, and more. With a focus on Australian laws, this program caters to both local and international audiences. Don't miss out. Enrol today for Cohort 1, starting 19th of September. Now, onto this week's episode.
From Flourish DX, this is the Psych Health and Safety podcast. With workplace mental health becoming a safety prerogative, this is the source of information on psychological injury prevention and health promotion.
And welcome to the Psych Health and Safety podcast. My name is Jason and I'm one of the hosts of the show. The aim of the podcast is to rapidly increase the knowledge and application of psychological health and safety in workplaces worldwide. To help with this, we have regular guests from around the world who are leading the way in this important area. But before I introduce our guest and topic for today, allow me to introduce my co-host, Joelle Mitchell. How are you today, Joelle?
I'm all right.
You're just all right?
Yeah.
It is Friday.
Yeah. Didn't have the best sleep.
Yeah.
That's okay. That happens.
You're going to go back to a 4-day week for a little bit?
For a little bit, yes. Yeah. My second year of taking some proactive fatigue management strategy.
Yeah. And this is it, right? Like, your leave is an entitlement, and a lot of people don't use it that way. I think it's great. I think more people should think about annual leave like that. You don't need to take 2 weeks off at a time, but reducing your work week by using your annual leave. I think if you've got a great employer like myself who's accommodating, that's terrific.
Well, yeah, and I guess using it that way as well is if you're worried about impact on your team and team capacity and that sort of thing, then it's actually less coverage, less
emails being built up on.
That's it. That's
2 weeks.
Yes, I will take 2 weeks off at some stage as well, though, because you do need the longer portion of time to properly recover.
Yeah. Now, Christmas is a good time for that.
Yeah, it's also an expensive time for that.
Yeah, this is true.
If you want to actually go anywhere and do anything.
Yeah, but you don't travel that much.
Not recently. No, I used to travel quite a lot. Now that I am limited to traveling in the school holidays, it's quite a bit more expensive. So, and some family health stuff has made it a bit difficult to travel. So hopefully we'll get back into that sometime in the next 12 months.
Yeah, I'm sure Ronan would enjoy it.
Depends where we go.
Legoland?
Maybe.
Code Camp Germany.
Yeah, it's a bit hard to pick what he'll enjoy or not enjoy. But I don't know that he'd like the German food very much.
Yeah, okay. Picky eater?
Yeah.
Yeah. Just some sauerkraut.
As long as there's some chicken nuggets, he'll be all right.
Well, luckily McDonald's is in most countries.
That's true. Yeah. It is in most countries, yes.
Cool. All right. Well,
guest.
Look, guest. We do have a guest today.
Yeah.
Joining us from Adelaide. So she is a musculoskeletal physiotherapist and started her career helping people to recover from life-changing work-related injuries. She then moved into injury preventions, which a lot of people do, but within SA Health, and discovered a passion for systems analysis and finding unique solutions to complex safety issues. She's now the principal work-fit services consultant at Northern Adelaide Local Health Network. Welcome to the podcast, Dr. Kate Harris.
Yeah, great to be here. Good to talk, all things safety.
Yeah, and glad to have you on. As is usual, when trying to get government workers to join, there is a lot of approval processes. So thank you for going through all of that bureaucracy for us, Kate, to be able to come on and talk to us on the podcast.
No, very happy to be here. Good to share what we're doing and certainly to inform and learn from others in this space.
I'm sure our listeners are going to get a lot out of this one.
So before we get into that, can you tell us what podcasts you like to listen to, Kate?
Oh, well, I have to admit, I'm a bit of a LinkedIn scroller, and I do like to see what the rest of the world is doing in the safety space. And certainly with all the energy and enthusiasm for psychosocial safety at this time, I love to see what's happening from the Flourish DX point of view, all these little bits of, I suppose, words of inspiration that come through, and certainly listening from the ODL and to the organisational psychs talk about their approach as well. We learn a lot in that space that we can bring back into that safety realm. So I have to admit, I'm wide and varied in what I'm listening to, and pick something and learn something from every single one.
And can you tell us, please, about your professional career?
Yeah, so thanks for the little summary there. Uh, I think being a physio by trade, taking that sort of biopsychosocial approach to health and safety has always been really, in my blood. So started in the injury management space, hands-on in the clinic, trying to get people better from their work-related injuries and illnesses. And then I really, I suppose, understood that in order to make change and prevent these, that we needed to move out of that reactive space. So I moved into SA Health. I was very lucky to pick up the work fit position, which is broad and it looks at preventions and health promotions and allows us to apply that biopsychosocial model. And then more as I've moved on and through the system, we've been able to look from a risk management point of view at what is best practice in this space. How do we take the physical injuries and the psychological impact that they have, as well as the psychological injuries on their own, and integrate that into our risk management system so it's every day and it's operationalized. We understand it, we can apply it. And most recently, I've taken over the wellbeing and resilience activities for NALAN, and that's been an excellent opportunity to look at the psychosocial hazards that we see within health and say, well, what is best practice? How do we improve and take that quality improvement lens? And again, how do we inform the business of its risks and identify suitable controls, so we can perform well. We have a lot of people to take care of. We want to deliver exceptional care to our community. And in order to do that, our staff need to feel safe. So that is the way we are going to get this great care, is that we can perform and we can feel safe in order to allow us to perform to the level that we need, particularly under times of, stress and demand within our system.
Yeah, so it's really started out in that tertiary interventions field and have moved into the primary prevention approach. Awesome.
Yeah, we love to see those people who are doing more injury management go to more systemic type interventions.
Mm.
I think a lot of people like you, Kate, who go, oh, so sick of just pulling people out of the river. We need to go upstream.
Yeah, absolutely. But all learning along the way, and it all feeds back, into the system, doesn't it? So I think if we can take that sort of really broad approach and say, how do we make sure that the preventions feed into the management and that we learn from that, and we're continuously trying to improve and learn from our system. Yeah, and really excited by the progress we've made over the last couple of years.
Yeah, and you mentioned LinkedIn earlier, and that's how Joelle and I usually find guests for the podcast. We see people who are doing good work, and then we reach out, and you kindly accepted my connection request and conversation around what you've been doing. So you've been building a tool to help calculate psychosocial risk on a 5x5 risk matrix. So can you tell us about why you embarked on this project first of all?
So Nalan identified probably early mid last year, when we were looking at our approach to psychosocial safety, that there wasn't a clear matrix that suited our needs in order to assess the psychosocial risks within our business. And I suspect this is something that a lot of other people have come across. But when we look at that risk management process and we go, well, how do we identify our hazards? Then how do we assess our risks? We need this matrix to make sure that my decision is the same as your decision. So there's a consistency in the application, that how we're determining whether something is high, low, medium risk is transparent, particularly when it comes to psychological injury. We want to make sure that, what one person thinks is low, another person might think is high. We need to be very transparent in how that decision was made to make sure that it addresses the individual need and it also gives a balanced approach to organisational risk. And we also noticed that the matrix didn't consider the individual as much as the organisational risk when we looked at our traditional matrix that was being used. So we decided that we were going to embark on a bit of a project to find something that suited our needs or develop something. And actually, when we looked at what was available through other industries, what was being used internationally, there were examples of 3D matrices, but none of them suited our needs. And the reason that we needed the 3D matrix was, as you know, the code of practice specifically refers to severity, frequency, and duration of exposure. And so our usual 5x5 2D model wasn't able to capture the duration as a contributor to mental strain and psychological injury.
Yeah, that's right, Kate. Because I guess a lot of people a lot of people who listen to this will be very familiar with 5x5 matrices, but generally you've got likelihood down one side, and then you've got consequence, which might be severity, for example, on the other matrix. But like you say, if you want to capture a third kind of characteristic of psychosocial hazard exposure and duration, then you're not going to be able to necessarily capture that on that 2D matrix, like you say.
Yeah, absolutely. And we do see within really high risk industries like mining that there is this 3 axis matrix used, but it didn't suit the needs for us in health. And as we've gone along, it doesn't seem to have suited the needs of other agencies as well. We also need a matrix and a way of assessing risk that is able to be used by consultants and experts within safety, but also our HSRs and our managers who might be new into this space. So it really needs to be user friendly enough and accessible enough that we can really embed it into our everyday. So whenever there is a report that comes in, whenever someone raises a hazard, we have a transparent, clear, consistent method for saying we believe this is a moderate risk and therefore here is the action that aligns to it. So with a lovely collaborative across a lot of different government agencies, we were so lucky. We were able to develop our 3D prototype and then do some reliability and usability testing to inform that final product. And we were very open with our HSRs. We got Safe Work Mentally Healthy Workplace Advisors, OCPSE Mentally Healthy Workplace Advisors, and union representatives as well to come in and say, what does this look like? When it's best practice for us. And certainly wasn't something we could specifically pull from the literature. So it really was a process of getting expert opinion together and saying, how do we make this work and, continue to review and improve it as we go, depending on what feedback that we get.
Yeah, and thinking about those end users, that's quite a mature step that you're taking, considering HSRs and leaders being some of the potential end users for this. We see the maturity where most companies are at currently is more at this is something that health and safety are going to do for you, rather than thinking about how do we empower others to kind of make it more embedded into business as usual, if you like.
Yeah, so we were very lucky with the feedback and enthusiasm that we got from Nalan leadership as well, and having our HSRs there willing to give us that feedback and being quite honest. This was about what is going to work for you within the context of health. So knowing that we are geographically dispersed, knowing that some people don't have access to computers, it needed to be available, on mobile. It needed to be simple enough from the user point of view that people were going to be accurately inputting their information in, but also we needed to make sure that it fit with our current system for risk management so that things weren't getting lost or duplicated. So we need a way of bringing it back to our safety learning system as well. And it's been actually a really interesting little process. And we are now at the point where we have it within our intranet, so access for all SA Health users, and we are embedding it into our assessments of psychosocial hazards whenever they arise.
Do you need more psych health and safety in your life? Then head over to the Flourish DX Academy for several free on-demand e-learning courses. If you're an internal professional, follow Flourish DX on Eventbrite to register for any of our free fortnightly interactive webinars. Our flagship professional practice program is also exclusively available for internal professionals. The 12-week course blends theory, applied practice, and interaction with other professionals through live lectures and a monthly community of practice session. Find out more about all these learning opportunities or inquire about a bespoke in-house training at the Flourish DX Academy. www.45003.org. Now back to this episode.
So you've given us, I guess, a brief overview in particular of the stakeholder groups that you were working with, but can you give us, I guess, a more detailed overview of the process that you followed to develop the tool?
So we decided to do the sort of literature review and to connect with mental health experts that we have within health. We decided to look to see what else has been done in this space. So the first process was bringing together what is close to what we want, and then trying to identify what are the things that are not working with these particular models that already existed. Then we started to break down, well, we know we have frequency and consequence, as you were saying, Jason. We have those already on our matrix. So we know those. Duration needed to be considered completely differently. So there is no set criteria for duration. What I think is short term, you might think is longer term. And we've had these conversations over and over to say, well, how do we, determine what are the 5 categories of duration that we are going to put onto our matrix? So again, expert groups, working groups coming together. What do we know? What do we believe is going to work the best for us? And how does the data that we already have in our safety learning system inform these durational categories as well? All right. Then we put together our prototype. We sent it out to our HSRs. We have a lot of consultative committees. So it was put out for consultation. It came back with some bits of feedback that made us say, look, it might be either this part is being misinterpreted or this part is not clear. The consequence categories was another one that we had to basically develop with the expert group and then put out for broad consultation as well. So we're looking at the effect on the individual here rather than the organisation. And so to be able to say this is a lower risk, moderate risk, high risk, extreme risk for an individual's presentation, that was probably the most complex conversation to be had. So the idea of this calculator was that it could be used by people who are not mental health experts, and we from the safety are not mental health experts. So how would I determine what the impact of this event is going to be on an individual? So I can't proactively or preempt the fact they're going to get PTSD or cardiovascular symptoms. What I can do is look at the presentation in the moment. So how do I, talking to this person, make a decision about the impact of this event on them as an individual? So that was the lens that we took it from. And then how would that look so that I can complete this risk assessment based on what I'm being told, what I can see, and what I know about the environment, systems of work, and all those other interacting components as well. Yeah. So really after that, we got our feedback. We did some reliability testing with our user groups. And then the main points of feedback were that we are geographically dispersed and that we need to have it accessible, as well as the 3D matrix was too visually complex. So that's when we really solidified that idea that it needed to be a virtual tool that could be accessible by all. We were very lucky to work with our communications team to develop a little prototype as a HTML file and then move to a Power App in order to get that final product.
Can you tell me a bit about the type of situation in which you would be using the tool? It sounds like it's more of a post-event tool to evaluate the risk to an individual at that point in time? Is that
We intended for this to have a proactive approach as well as reactive, so that it was part of the criteria when developing this tool. So again, from the proactive, we might look at the organisational risk where we didn't have an individual to actually talk to. So if someone said, you know, visitors are coming through the front door and they're upset, obviously we are a trauma facility, and so we need to expect that within our business model. How do we know how much of a risk this is? Then we would still use that frequency, duration, and severity consequence to look at an issue proactively. So we would generally look at organisational risk in our consequence in that situation. For an individual, so say someone was walking to their car and they got scared by somebody who was walking around, in the general public on their pathway, we could say, well, we're going to look at that particular individual and how that's affected them um, to develop their consequence, and then look at that duration frequency as well. So we'll try and provide a proactive and reactive option. But you're right, it tends to be a risk assessment for a specific incident or hazard as opposed to a broader organisational risk assessment.
So, how did you end up conceptualizing then the consequence or severity and frequency and duration?
So frequency was probably the most simple. That stayed very similar to our traditional model. The consequence, again, we use that expert group to come in and say, what would a moderate consequence look like? What would a minor consequence look like? A major and extreme. And then we're looking at the organisational impact as well for minor, moderate, major, extreme. And that's really about the tolerance of any organisation. So the consequences is really about your risk tolerance. All right. So for some organisations, particularly first responders, things where the business model requires some exposure to psychosocial hazards, and that's part of the actual work that's undertaken, they might have to have some tolerance. So, for example, I come back to us being a trauma sort of service or someone like SAS, there has to be some tolerance for that. If we look at, say, bullying and harassment, there should be zero tolerance, for those sorts of hazards. In mining, they might have to have a slightly higher tolerance because of the amount of risk that they are coming across. So the consequence table is really about, for us, how do we see our risk tolerance played out? And again, how do we minimize that? But where do we have to have a little bit of give? And where do we say, you know, that shouldn't be part of our business plan? We're not going to accept that.
Yeah, and that's a really good point to make around appetite, and based on the business model, what is it that people do, and what is it that you can't eliminate or reduce to a risk that is low enough. I'm interested where you ended up on the consequence, because on your traditional health and safety 5x5 catastrophic consequence is usually multiple fatalities, but what we're talking about here is individual impact. So I'm interested to know what was the top impact that you identified versus like a moderate impact.
Okay. Would you like me to share the calculator?
Well, we can't share it on the screen because this is a podcast.
Okay, I just thought, but there might be a way of doing it here.
If there's an
Um,
image that we can share later in the show notes, that would be
yeah,
great.
yeah, that's right. So if we're looking at extreme, obviously when we get to the extreme category, we have to be covering off on the most extreme events. So the extreme category does have to cover off on the worst cases, and we hope, and we've never have had to use that, but we do need to look at a fatality, and particularly when it comes to psychosocial and psychological injury, obviously we have to look at self-harm and fatality. So we would like to say that we don't wait for that point to say it's extreme, because obviously we don't ever want to have to get into that space. So rather than saying when it's at the point that someone suicides or there is a fatality, that becomes extreme, we've actually dropped it back from that. So if there is a risk of self-harm, if it has got to that point, if that person has needed to engage with a hospital, then that is already within its extreme. And we need to be able to ensure that if a situation arises where someone is in that situation, that the extreme risk rating allows us to immediately escalate that concern to the level of the organisation that can respond and put in appropriate controls and reduce that risk as far as reasonably practicable. So we do want to make sure that extreme category doesn't only focus on the reactive or those absolutely extreme end events.
Yeah, and that's consistent with some of the conversations we've had internally at Flourish DX within our team around, when you're talking about a safety impact and someone, having to have attend hospital, medical treatment case kind of thing, then that might be a moderate consequence usually. But what we're talking about when it's a mental health consequence is if they're going to hospital for a mental health issue, it's quite extreme, like you say.
Yeah, and that's certainly the feedback that we've had from the organisational psychologists as well, is what is seen as a minor. People tend not to attend unless it's really in that extreme.
Yeah, and I mean in the public health system at least, admission for psychiatric care does sort of or is necessarily limited to the very extreme, very severe cases of ill health anyway.
Yeah, and when the health system in general is under a lot of pressure, um, then yes, that can put barriers up as well. So absolutely, and we hope we'll never need it.
And what about the duration then? How did you conceptualize duration? Because you said that was the most difficult one.
It was tricky, wasn't it? Because what is short term to continuous is where we need to go. So we need to be able to account for those brief, severe consequence situations that might happen. So if someone had quite um, a nasty experience or quite a threatening experience that would maybe only lasted a couple of seconds or up to a minute, um, that's still a very serious event. We don't want to undermine that. However, when we look at psychosocial hazards, they tend to be, because they're about systems of work and they're about generally longer duration hazards. So we have had to look at duration from a slightly broader, longer term perspective. So our short term actually covers up to a week. And while there was pros and cons for that, so why doesn't short term cover, a sort of two minute sort of event? Well, it does cover a 2 minute event, but we need to be able to keep to our 5 categories to reduce the complexity. If we went to too many layers of duration, then the complexity tends to override it. And also, we're confident that where an event happened that was short duration, the consequence ratings would allow it to still be reflected as a high, or extreme sort of a risk. So we were able to find that we could balance out keeping the short term at that week duration and still have short term, sort of quite severe incidents reflected in the risk rating at the end.
Yeah, I'd imagine it would be quite hard just having the 5 categories. We found it hard enough in our own risk assessment tool, which has 10 categories, to be able to capture the whole kind of duration continuum. But yeah, then we can capture at least those very short ones. One of the discussions we've had internally is it more important to capture the duration of the hazard exposure, or is it more important to capture the duration of the stress experience due to the hazard exposure? We ended on the latter in our case because it's actually the elevated stress response that causes harm rather than necessarily just how long you've been exposed to the hazard for. So in terms of those highly stressful situations like exposure to violence or trauma, for example, yeah, the incident might only last 30 seconds or less, but the person might have that elevated stress response for maybe potentially days following that experience as well. So how did you conceptualize that? Is it more around the hazard exposure, or is it around the stress response due to the hazard exposure?
So we have taken the approach of exposure to the hazard. Number one, this is a sort of safety lens to it, and that is how we generally assess occupational hazards from the safety perspective. And secondary, because we are having users that may have varying levels of expertise in this, being able to judge what the stress exposure and duration would be, I think is too much to put on the individual. So we
Yeah,
do.
yeah, sorry, Kate. Yeah, and I get that because you've got people making a judgment based on other people's experiences, whereas with ours, it's about the person's own experience. So yeah, it's a bit harder when you're trying to guess how long someone's been impacted for. So yeah, that makes complete sense. Yeah.
Yeah, so it's just different. Yeah, it's different lenses, and I think it's probably your particular system and approach and this one have different areas of use, but they also complement each other as well. So having that ability to see the broad picture and that broad organizational risk, and then for a particular episode or incident, we would bring in our calculator to say, for this specific scenario, this is how we're going to assess it.
Yeah, and we'll get to it. There's definitely utility, and I guess much less operational impact if you've got people who can do the risk assessment without having to do broad consultation with workers.
So, what is the output from the tool?
So the tool provides a risk rating with a number as well. So it provides a scale to you. So you would put in your consequence, duration, and frequency selection. They are drop down lists, and you will end up with a low, moderate, high, and a corresponding number. So the numbers go from 1 to 39. The higher the number, the greater the risk. The output will also give you worker and manager immediate actions. So, what we wanted from this was, okay, I'm a HSR or I'm a new manager. This risk has presented itself, or I've got this report from a staff member. This is my assessment. Now what? So we understand that following up on these will be slightly more complex. We know that there needs to be investigations and there will be ongoing impact, but we need that immediate action. We need the right immediate action from the worker, and we need the right immediate action from the manager. So it's about building the confidence of the manager that they can respond quickly and appropriately, and they're not umming and ahhing about what is the right thing to do. So we're trying to build that capability, make sure that our system is picking up on this data, so we're not missing reports and we're not underestimating something, or not able to actually get that data into our broader system. And that's where we see our bigger pictures um, of our hazards and risks across the organisation. And it also allows the manager to then, when they've identified a control, recalculate that risk. So if they've been able to drop the duration of exposure, drop the frequency, drop the consequence, then they can see if that, high 20 turns into a high 14, that particular control has had a positive effect. So the calculator is really used as a way to say, where are we now? And we know that assessment and that sort of high, low, moderate is important because that's where we flow our information to different levels of the organisation. So we need that risk to get to the people who, number one, have a legislative obligation to control it, but also have the delegations and the knowledge to be able to say, this is what we need to do. And we need the managers and workers to understand what they can do immediately to control it, and then hopefully follow up with, what is reasonably practicable, which one is going to make the greatest impact and reduce the risk the most as well. So there's several ways it can be used across the organisation depending on the issue.
Yeah, so it's great that it does give those practical actions out of the back end of it as well, that it's not just sort of an input that then goes off into the ether and you're kind of left with, well, what do I do next? So yeah, good to hear that there are those recommendations that come out of it as well.
Yeah, we hear that all the time from people saying, "Oh, well, what can we do about it?" And we like to give people some, and I think your tool does the same from memory, Kate. It provides some practical examples of what you might do, but ultimately, you really need to think about what's contextually relevant, and where possible, sourced by the employees themselves, so that they're participating in the development of the controls.
Yeah, absolutely. And I think having the employee input as well means that there's not someone else making a decision on how stressed you are. This is all meant to be done with input from the person affected and other people that might know the systems of work, like the HSRs as well. And it's attached to our safety learning system, so it's there. And again, it means that where we're dealing with things that are emotional, where people don't agree on what the level of risk is, it's a way of bringing everyone together and saying, this is, what we're choosing. It's out in the open. No one's making a decision, that's not transparent to everyone involved. And if you don't agree or more information comes to light, we can put that in, we can take that into consideration as well. So I think the most important thing for us is that the decisions are made openly and in collaboration with those involved and those that have knowledge of the environment, tasks, and systems as well.
I am interested. Does your tool look at interactions of hazards? I mean, using the example that you mentioned before, like first responders, right? We know that there's certain hazards that they will be exposed to because it's part of the job. So they have to attend, unfortunately, fatalities and these sorts of things. But then you would say, well, the cumulative load of psychosocial hazard exposure through other things like work overload, low job control, those sorts of things. Well, we probably need to be even more mindful of those other hazards because we can't reduce the trauma exposure to a low enough level. So we better make sure that we're reducing the work overload and the low job control components as far as we can, or further than what we would for other populations, because we want to reduce that cumulative exposure of psychosocial hazards. So does your tool kind of pick up on that at all, or is it looking at each hazard in isolation?
Yeah. Look, agreed. And I think this is probably another step for it. And it does add that level of complexity. When looking at interacting hazards, our approach at the moment is whatever hazard has the highest level of risk is the overall risk rating, right? So if I had work pressures and organizational justice together, and one came out low, one came out moderate, then as an overall risk rating, I would put it as moderate. And the reason for that is because we need the controls to be managed and put in place at the right level of the organization. So we're going for the highest of all of the combined to make sure that the risk is escalated to the right people who have the ability to make decisions and put in place the appropriate controls. But I absolutely agree, if this would require a formula, like an exponential formula. And part of when we were developing this tool, we were saying, well, does this formula exist? What is the mathematical model? And what would be the research that backed that mathematical model? And it wasn't necessarily available. It didn't come to light to us. So if we're looking at what research or evidence do we have to say that uh, you know this particular duration would exponentially increase stress, like it's a tricky one. I think it would be great to have a master's project or some further work in that space, but it was slightly outside of the scope of what we could do within our time frame and remit. But it would be a great next step to say, how do we look at that? And I'm sure that's something you were able to look at in your model as well. But yeah, haven't quite got to that point yet. Is that something that you've done as well?
Let's just say the models do exist. They're just not in the public domain. So
Yes. Okay. We might have to, yes, talk further about that. It's
yeah,
great.
we've got some very clever people who continually developing and validating the model to look at that cumulative load and how that does increase risk. But no, it's I think what you're doing in the absence of that, taking the highest risk and saying, well, that's the risk, rather than taking an average. That probably makes more sense. How's the tool been received so far?
So we're still getting feedback from it, but actually it's been received quite well. We're certainly not finding that the access has been a barrier, that people without expertise, particularly in safety, are finding it complex to use. And if you see the interface, it's quite simple. And that was the idea, was that from the user perspective, we wanted to keep that simplicity, and all the, all the complexity is really in the background. So in terms of being able to integrate it into our current safety learning system, we've had no particular issues. We are doing 3 monthly reviews, and we're still seeking feedback from our HSRs and from our Work Health Safety Consultative Committee. And we do plan to have another review in a couple of months' time to say what might need to change. But certainly at this particular point, it is absolutely meeting our needs. And I think when the energy and opportunity comes around to say how might we rethink it and take it to that next level of complexity, that would be really exciting at the moment. But we were very happy to get some union representatives to review as well, to make sure that that external lens is on it. And certainly there was no feedback that stopped us from progressing, and we were able to integrate all the feedback that we did get into the tool before it was finalised. So happy with it at the moment. It's been a great little project, and good to see it helping in the everyday. This is really about making this easier to negotiate, taking away that complexity and removing barriers, and just saying this is the best we have right now. It's tailored for us. If this is going to help clear the path forward and make dealing with issues quicker and easier, to make sure that we can reduce strain and stress wherever possible, then that's great for us.
Yeah, well, it's great to see that level of innovation within public service. Often we find that, public service is really beholden to academia, going, well, does it exist somewhere in academia and can we take that? Whereas what you've done, obviously, is done a large level of consultation, consulted with the evidence base, but then design something in consultation that ultimately meets your needs far better than anything off the shelf. So, yeah, kudos.
Yeah, we've been very lucky. Like I said, we had a great, very passionate group of people that gave their time for this. So thankful for everyone that was involved. It was yeah, it was a good project.
Well, and a project like that also needs the right advocate who is able to build the the case, or the need for developing that as well. So you're sharing credit, which is what every good public servant should do. But I think there's definitely a lot of that credit for you as well. So congratulations.
I love having those moments, when you identify a gap and go, wow, this is surprising, but this is awesome. This is a great opportunity to say, what can we do in this space? So yeah, it's been fun, little problem solving activity on the weekends and things. But yeah, nice that we get a finalized result. And look, if we can, keep the health workforce doing what they do best. We are, as a system, there is a lot of pressure on us, and I think all these little things help clear the way and help us to provide that exceptional care. So, but thank you, that's nice.
So what's next for the tool?
So we're going to be expanding access. So at the moment, we've had a number of other government agencies ask for access, and we are just working with our IT and communications team members to see how we can best achieve that. That's a little bit out of my remit and not my area of expertise, but absolutely, we always wanted to share this. And even if the tool doesn't fit all agencies' approach and appetite or tolerance, then if it can give a foundation for them to say, we can actually work with this and we can develop our own, and I hear a little bit of that. It's like, we're going to do this and we could do this. That's great. That's what we wanted, was to start that conversation, because I think sometimes we feel like we can't see the wood from the trees with psychosocial hazards. So this is really about saying, this is where we're at, and what can you do in your space. So we'll look to expand access, and then really it's about the feedback we get, and if we need to tailor, if we can find ways to improve the tool, And if we can find ways to then further provide access outside of government, then we will. But at the moment, we're just taking it one step at a time.
And so is that currently just the South Australian government, or is it broader?
So the tool is available to all SA Health employees. And at the moment, and then we are hoping to expand that across all South Australian government agencies as required and where they wish to access it.
Well, Kate, you've listened to the podcast before, so you know the question that's coming. If you were to look into the future, what would your hopes for the future of workplace mental health be?
I think finding that nice balance between what we need to take, I suppose, action in ourselves and what the workplace needs to take action in. Uh, I'm hoping that the future will be a place where we've built the capacity of people to look after themselves, to raise, issues early, to speak up early, and we've also built the capacity of organisations to think proactively about mental health when we're designing environments, when we're looking at role descriptions, when we're developing policies. If we can take that proactive lens and think about what are, I suppose, those characteristics that make for great jobs, great work, great productivity. Uh, if we can find that nice balance between the two, I think that would be a great place for us. In the slightly shorter term, I think bringing together human resources, organizational development and learning, and safety together more and more is really going to be the next step. And I think that's probably fairly obvious from your perspective as well, that increased collaboration between units and between agencies to make sure we shared learnings, but we also have this very broad holistic approach of that people experience. I think that will be the short-term step for
Yeah, I
us
like
all.
both. I like both of those. Yeah, so the shared responsibility, right? Not just putting it on individuals, but organisations. But then the other one is the silos. I had an interesting conversation earlier in the week, and someone referred to silos being the villain when it comes to psychosocial risk management in organisations, right? So how do we overcome that and get people working collaboratively, sharing data, and coming up with shared solutions and leveraging different mental models, right? Like health and safety will look at this differently to what HR or wellbeing will look at it. So, no, I love both of those, Kate, and I think you're right. Short term, long term, there's some good solutions there.
Last question for you, Kate. What are your words of advice for listeners who want to work in the field of psychological health and safety?
I would say it's an evolving science as such. You're not going to be able to apply any preconceived model, I believe, to any one organization. It's really about learning what your needs are, what your risks are, and what works best for your particular people in their particular environment. So if you came into psychosocial health and safety thinking that what worked for one, your last employer was going to work for this one, I think you'd be disappointed. It really has to be a very open information gathering sort of lens. And then I would say, don't be concerned that you can't see the wood from the trees. We know that the inbox gets filled up with million different well-being ideas and strategies, and I think sometimes we feel overloaded. We feel like we have to solve the world's problems. This is about creating great systems, great supports for people, and great work. So you may not be able to change the world for someone, but within their occupational space, if we can make sure they have the support, the environment, the systems there, and we always have this quality improvement lens, then you'll get there. And I think it's always a little bit of a work in progress, isn't it? We're constantly learning and reviewing to do better and better. So it's an evolving profession, I think, from our perspective anyway.
That's some fantastic advice. Thank you, Kate.
Okay, it's been a fantastic conversation again. Kudos for all the innovation that you're doing over there. Where can people find out more about some of this work that you've been doing?
Well, we will be working closely with the OCPSE, and we'll also be working through with the Safe Work SA Mentally Healthy Workplace Advisors. So if there's any more updates or any changes, any expansion of access, then we'll make sure that we update those particular agencies and we can promote that out um, to all your listeners.
That's terrific. Well, again, Kate, thanks again for joining us and going through all the hoops that government workers have to go through to appear on podcasts like this. I know our listeners would have really enjoyed and appreciated your insights.
That's great. Thanks so much for having me. And yeah, good luck to everyone out there listening. Keep going.
Terrific. All right, listeners. Well, that brings us to the end of this episode. Remember, we do record these over video when we have our guests on, and you can catch those videos, over 200 of them, on the Flourish DX YouTube channel. We also take the snippets, the best of these conversations, and put them on the Flourish DX LinkedIn page. While you're over on LinkedIn, Joelle and I are there, as is Kate. That's how we got connected. So feel free to reach out to us, and if you want to keep the conversation going. But that's it for today. We'll catch you next episode.
You've been listening to the Psych Health and Safety podcast. To stay up to date with the latest on psychological injury prevention, follow Flourish DX on LinkedIn and subscribe to the Psych Health and Safety podcast at www.psychhealthandsafety.com.